Ladies and gentlemen, I'm going to present our hyperthermia experience in the last 30 years, which was started under the leadership of Professor Issels in the treatment of high-risk soft tissue sarcoma combined with chemotherapy. We started 1986 with a phase 1 study for chemo pre-treated patient with extremity and non-extremity tumor with etoposide and efzofitimod. And after phase 1 study, we started 2 studies of phase 2 with neoadjuvant chemotherapy in non-pre-treated patient, and after that was the randomized phase 3 study, which was multi-center study and published 2010. The result of the first phase 1 study that we have published, that there is a relationship between radiological response and treatment outcome. So temperature in the tumor means after 4 cycles of chemotherapy and hyperthermia, a reduction of tumor volume in the patient, and that mean after that zero resection is possible. And the next result was that we have published that the response on hyperthermia combined with chemotherapy is predictive for long-term overall survival in retroperitoneal tumor. This both most important result was the reason was we were able to starting the first big randomized phase 3 study with 341 patients randomized in chemotherapy and hyperthermia versus chemotherapy alone. And this result was updated 2016 and published again 2018 with the updated data. The presentation of the patient that we have randomized 169 patients in chemotherapy and hyperthermia versus 172 patients in neoadjuvant chemotherapy alone. This, after that 12 patients was out of the study, we have made the follow-up with 329 patients with a median follow-up was about 11 years. The treatment regime was designed as 4 cycles of neoadjuvant chemotherapy and 4 cycles of neoadjuvant chemotherapy combined with hyperthermia. Here it's important to see that we have the same number approximately in both arms, 162 in arm A and in B, and after that was the evaluation of response and the surgical resection. After that we have performed the radiotherapy and the definitive resection. And here see that we have the same number in definitive resection and the same number in radiotherapy in both arms. There is no bias of number of patients in both arms. The main point of the study was local progression-free survival. Local progression-free survival was because we applied a local therapy. Both patients received systemic chemotherapy, and only the hyperthermia is the local treatment which added to the chemotherapy, and therefore was the main point of the study, the local progression-free survival. The other second endpoints was tumor response and disease-free survival and overall survival. We see here the patient characteristic consisting of 162 versus 167, and we see the age of both patients is the same, 51 years, and the distribution of male and female in both arms is same. We have no difference in the performance status of the patient. Interesting to see that we have more non-extremity in both arms than in extremity patient. This is so the most patient of this patient collective are non-extremity patient, and we have the most patient were primary and prior resected patient. The baseline characteristic, we see that we have huge volume of tumor. The median tumor diameter was 11 centimeter in both group, and the range was between 5 and 40 centimeter. So we have treated big tumors. It was one of the risk factor of the high-risk defined soft tissue sarcoma, that the diameter of the tumor at least 5 centimeter. G2 and G3 in both arms as the same distribution. We have no G1 tumor, and the subpathology of the patient are most of them as the L sarcoma, lipo and leiomyosarcoma, same distribution in both arms. We come to the result. The first result is the radiological response, which was evaluated after 4 cycles of chemotherapy combined with hypothermia. And very interesting to see here that we have a partial response in the hypothermia arm with 28% versus 13% in the neoadjuvant chemotherapy alone. At the same time, we have in the progressive disease in arm A with neck and RHT, only 7% versus 21% in the neck alone. So we have 3 times response and 3 times non-response in both arms. And we see the overall response was 30% in the neoadjuvant chemotherapy and RHT versus 13% in the neoadjuvant chemotherapy alone. We see here the local treatment which was applied, as I have mentioned at the beginning of the presentation, that we have the same number of surgical resected patients and the same number of patients who have received the radiotherapy. The difference which we here see that we have 51 patients in R0 resection in arm A and only 41 R0 resection in arm B. That's due to the better radiological response on the arm A, hypothermia and chemotherapy, which it make able to receive a R0 resection without amputation or multilateral surgery. We have in the same time 7 amputation in arm A versus 9 amputation in arm B, and we see both number with radiotherapy. The main endpoint of the study, as I have mentioned, was the local progression-free survival. And it was definitively, this is the updated data for 2018, which was published in JAMA Oncology, that a significant benefit for hypothermia and chemotherapy in the local progression-free survival with 5.6 versus 2.4 years for the hypothermia arm. And now we come to the second endpoint. Despite the fact that we have given the patient a local treatment and both patient groups, they receive the systemic therapy, we have a benefit in the disease-free survival in the hypothermia arm with 2.8 years versus 1.5. And in the overall survival, we have here a significant benefit in the number of patients and in the duration, 15 years versus 6 years. That was the result, a clinical result of the study. And we see here in the first plot analysis that despite all risk factor of the patient, we have at each time the benefit of hypothermia treatment to see. We have radiotherapy, despite the fact if the patient received that radiotherapy or not, the tumor volume, the grade. This is here very interesting to see that in grade 2, which less sensitive for chemotherapy, we have more benefit for hypothermia than in grade 2. We see here in the subtype of sarcoma, L sarcoma or not L sarcoma, this is all patients have a significant benefit of adding hypothermia to the systemic chemotherapy. The most discussed question is the side effect of the hypothermia combined with chemotherapy. Here we present the side effect of the chemotherapy. As we see here, there is no significant increasing of side effect of chemotherapy, only we see it's in the leukopenia. We have in leukopenia grade 3 or 4, we have a significant more leukopenia in arm A than in arm B. We think that's the reason for this, that the most patients, as I have presented, that are patient with retroperitoneal tumors and non-extremity pelvic tumor. And we heat in our hypothermia treatment the pelvic, we heat the abdominal region, and we think maybe that's the effect on heating the bone and the producing of the blood is maybe a reason for the significant increasing of leukopenia, but we have no increasing of the other side effect of chemotherapy. As well. This hypothermia don't increase the side effect of chemotherapy. The last one is the adverse effect of hypothermia. The most adverse effect of hypothermia, which is important, is burn, as power-related pain, and we see here we have no savory side effect of hypothermia, which higher than 5% we have in the pain, despite the fact of this is therapy-induced pain or for the localization or tumor localization pain. We have the pulse pressure. That is a problem in the hypothermia, but it's only by less than 5 patients. We have skin burn, significantly low, only 1 case in the 169 patient which was treated, and the other localized side infection or other side effects are significantly not high in this study. Regarding to this result, which was published in JAMA and in Lancet, where the hypothermia was added in the NCCN guideline and in the European guideline for high risks of tissue sarcoma. And after this publication, we have received an application grading for the non-invasive hypothermia, where we use the MRI system to measure the temperature in the tumor, non-invasive, and to reduce the side effect of hypothermia, which is here not the main point of the publication, of the presentation. Thank you for your attention.
Thank you very much for this. Thank you very much for this very interesting introduction, and thank you also for keeping the time. Is there maybe one short question? We will have a discussion at the end of this session, so if there are questions that might involve also the other presentations, then you can keep them. Is there a very short question? If that's not the case, we could proceed to the next presentation.